Hello. Thank you all for joining me today on this presentation. My name is David Cohen. I am Medical Director and co-owner for Teleradiology Specialists. Our radiology group specializes exclusively in urgent care, and we have done so since we were founded 6 years ago. I've included here this slide with a few details about our group and the services we provide. I'd like to call your attention to the last bullet point. We are pleased and excited to announce a recent partnership with Practice Velocity, by which we will be able to provide a fully integrated overread service with Practice Velocity, so that when you place your orders into Practice Velocity, we will be able to receive them automatically along with the images, and that when the reports are completed, they will automatically return to the Practice Velocity EMR. On this slide, you will see our contact information. You can reach me at that phone number or through our website if you would like to hear additional information. The topic for my presentation today will be called Urgent Care, Radiology, Common Fractures, and Pitfalls. All of the cases we'll be looking at are actual urgent care cases that have come from the centers where we read for. We've collected these cases into a teaching file over the years, which we make available to the providers as an educational resource. We also use this teaching file to create educational presentations like this one. Typically, this talk covers all of the musculoskeletal body parts: foot, hand, wrist, elbow, so forth. But in the interest of time today, I'm going to have to limit it to just two body parts. We'll be talking about ankle and about elbow. This is our first case here. This is obviously a pediatric ankle, and I'm showing it for a couple of reasons. First of all, I want to draw your attention here to the medial malleolus. You'll see a few small ossifications here. This is a normal variant. These are accessory ossification centers, commonly seen in this age group, but often confused with avulsion fractures. I'd also like to talk a little bit about the lateral malleolus. This is, of course, a common site of injury in pediatrics, and it can be difficult to diagnose a subtle Salter fracture here. There can be quite a bit of anatomic variation along this growth plate and along the metaphyseal corners. There may be small punctate areas of calcification. The physis itself may be undulating, and you can see some irregularity on that basis. Keep in mind that Salter 1 injuries have a normal radiograph in over 50% of the cases. So we're not going to be able to exclude that Salter 1 injury by X-ray. That's more of a clinical diagnosis which can be considered if the pain is persisting for more than a week or so. Here's just another oblique view of this ankle showing the normal anatomic variation. Okay, moving on to our next case. This is going to be a bread and butter ankle case here, just to get us warmed up. So this is a young adult, comes in with a typical presentation of lateral ankle pain. We can see the significant soft tissue swelling there. And then, of course, right at the very tip of the fibula, we see this avulsion fracture. I want to point out that the avulsion fracture has this typical curvilinear kind of jagged appearance, and that is typical for an avulsion fracture as opposed to accessory ossification, which are commonly seen here, and those are going to be round and very well defined. Of course, we can't tell exactly the age of this based on its radiographic appearance, but the soft tissue swelling certainly would suggest that it is acute. Okay, I have another avulsion fracture to show you here. This one is less commonly seen, but it's actually interesting because it represents an injury to the most commonly injured ligament ankle, which is actually the calcaneal fibular ligament. That ligament, however, doesn't usually show up with an associated avulsion fracture, so we don't see it often radiographically. But in this case, The history was lateral ankle injury, and you can see next to the tip of the fibula, we don't see an avulsion fracture or any irregularity in the bone. But if you look just a little bit more inferior, you see this fragment of bone here along the lateral aspect of the calcaneus. Notice again that it has that sort of curvilinear, angular shape, a little bit jagged, very typical in appearance for an avulsion fragment. This arises from the attachment of the calcaneal fibular ligament. Moving on to the next case. Seems to be, we're going to look again at another type of avulsion fracture in the ankle. They seem to be one of the more common entities. And in this case, the fracture is only seen on the lateral view. Take a look at it here on this projection here. This is an avulsion fracture along the neck of the talus. Not a very common injury, but certainly this is one of the larger ones you'll ever see. You can even see a little bit of a donor site here where the bone was avulsed from. Again, just to reiterate again, of course, we see this curvilinear kind of jagged shape. Unlike the accessory ossification, which we can see here as an example, see how rounded and well defined that is. That's very typical for an accessory bone. In this case, it's an os perineum. You can also have an accessory bone right here near this talonavicular joint line along the corners here usually, and that's an os navicular, for example, that can show up here. Now it's going to be rounded and very well defined, so you don't want to confuse that with an avulsion fracture, which is typically more along the neck of the talus and has this angular type appearance. Let's see, let's do one more ankle. Where's that it for ankle? Oh, no, we do. We have one more ankle that I'd like to show you. This is an important, uncommon injury, but an important one because it can be debilitating if not detected early. So this is an adolescent patient who presented with some ankle pain. And, you know, as we go through our usual checklist here, which I definitely recommend you do, by the way, we never approach films in a passive way where we just look at it and wait for something to jump out. We always want to have a checklist in mind or written down with maybe 8 or 10 items where we're going to specifically look at actively. So that would, of course, include the lateral malleolus and the medial malleolus and then the talar dome. So the talar dome should be smooth and well defined. And in this case, on this view anyway, we sort of think, well, maybe there's a little bit of a lucency there right at that corner. That looks a little bit suspicious. And as we look on the oblique view, sure enough, here we have a great example of an osteochondral lesion at the talar dome. These are, with MRI, you can grade them, and the more severe lesions will be either loose or unstable. And in this case, with seeing the lucency completely surrounding this fragment, it would seem to be that it's likely to be loose or unstable. On the lateral view, I'd just like to point out that it's important on your checklist to include the anterior process of the calcaneus, which we have examples of fractures here in our teaching file, which I won't be able to get to today, but that's an important checklist spot that you need to include. Also, the subtalar joints should be on the checklist, and of course the base of the fifth metatarsal, where we'll often pick up avulsion fractures. Okay, moving on now, we're going to go to the elbow, which can definitely be a very tricky anatomic area for us all, which is why I'm going to start first with, pardon me, let me reconfigure this. I'm going to start first with a pediatric elbow here, just so that we can show what normal ossification centers look like in a pediatric elbow. Let's start with medial epicondyle, one of the first ossification centers that will be visible. It should always be located here very closely opposed to the humerus. Shouldn't be any space or asymmetry or widening in there. It should sit tucked right up close against there. The other ossification center that's seen very early on is the capitellum. And this is very typically just a large, single, well-defined ossification center, as opposed to the trochlea, which is next to it, shows up later and is almost always a multipartite multifocal type ossification center with a little bit of regularities. You can look around it and see little areas of calcification all within it. This is a typical normal appearance for the trochlea, unlike the capitellum. Over on the lateral side, we have the lateral epicondyle, which is very different in appearance from the medial epicondyle. It's typically going to be a little bit lower, closer to the level of the capitellum. It has this oblique orientation and is multipartite, so you'll see a lot of smaller areas of calcification. So you don't want to keep this in mind. You don't want to confuse these with fractures or fractures of the trochlea. And then we can also look at the olecranon. This apophysis is one of the last apophyses to fuse in male patients. It may not fuse until the age of 14 or 15 years old. The last part to fuse is going to be this little part right here in the dorsal aspect. So you may see a 15-year-old with a little lucency left right here, and that's going to be just the last bit of the growth plate which hasn't quite fused. And those are commonly confused for fractures. The other source of confusion with the olecranon are these small accessory ossifications. Very typical to see these. These are not going to be fractures. You may also even see a bipartite apophysis here, so you have a lucency or a line going right through this center here, and those are all within the spectrum of normal variation. Okay, so let's show some abnormal. We can start with this. So this is a young patient presented with an elbow injury. This is younger than the last example we looked at, because you'll notice at this point in time we only have 2 ossification centers visible. It's the capitellum, and we know if you see the capitellum and nothing else, and one other bone, it has to be the medial epicondyle, which it certainly is. But what do we see that's different about this medial epicondyle? It's not tucked in here really close to the humerus the way it should be. So this is definite abnormality. We can even see overlying soft tissue swelling, and this is an avulsion of the medial epicondyle. In a severe case, this bone can be avulsed and pulled down by the tendon and may even project in this region, which could be confusing. It could be mistaken for an ossification center at the trochlea. But you have to keep in mind that you would never see the trochlea and the capitellum without seeing the medial epicondyle, since this is one of the first ossification centers to form. So that could be a potential pitfall. All right, moving on, we're going to go to another pediatric injury here. Well, let me flip that over for us. All right, so here's another young patient here presented with an elbow injury. And here we can go through and see all the ossification centers. This is the medial one, closely opposed to the bone as it should be. Here's lateral, a little bit more inferior position. Now look at the capitellum here. We talked before about the capitellum should always be one large single ossification center. Unlike the trochlea, which can have little areas of fragmentation and multicentric, capitellum should not. So when we see this extra piece of bone here, this is definitely going to be an abnormality, and this is an osteochondritis dissecans of the capitellum. It's analogous to the osteochondral lesion that we saw in the ankle along the talar dome. These can be loose and unstable fragments. It can be a debilitating injury. So very important to recognize or look for any irregularity or lucency along this capitellum. Okay, moving on. So one of the most common elbow fractures in children is actually this fracture here. This is a typical appearance for a supracondylar fracture of the distal humerus. You can see the fracture line obliquely right through here. It's disrupting the anterior cortex, and we have a little bit of angulation. It's interesting, however, if you look at the other views, very difficult to detect that fracture on these views. This would look almost normal, wouldn't it? Even on the oblique view, really can't see this fracture at all. I think it's a good opportunity to highlight the importance of having good views in multiple projections. It's not uncommon at all in urgent care to have a fracture show up on only one view. So if we're taking just AP lateral views, we're going to miss fractures because there are fractures that will only be seen on an oblique view. Or in a child, if we don't have a good lateral view, we could be missing fractures like this. All right, I want to show at least one adult elbow injury. This would be the most common elbow fracture that we see in adults by far. It can be a very subtle injury, as in this case. The fracture is visible on this view. Let's take a look at that before I give it away. And then we'll look at the other views. So here's a nice oblique view, and I can tell you I don't see anything on this view. Another oblique view. Very subtle. Really what we're doing when we're looking at adult elbows, we know how common the radial neck fractures are, so we're always looking at the radial neck for any subtle abnormality at all. This right here, this would catch my eye. It doesn't look like much, but it's just a little indentation of the cortex. I would certainly be wondering if there could be a nearly occult radial neck fracture there. Then moving on to the lateral view, what we see is a very large joint effusion. That can be seen here as the Sale sign. Okay, this is commonly talked about, triangle here of fat that's uplifted, but I find that to be really unreliable. It can be present without an effusion, so I don't really hang my hat on that. But the posterior fat pad sign, which we see here, is very reliable sign. Typically in this location, the sort of gray density from the muscle should be directly up against the bone. But if we follow this interface down right here, we see this uplifting of fat, and that lucency there, that's the posterior fat pad sign. So this guy's got a large effusion. In addition to what we saw on the previous projection was that little irregularity along the radial neck. This would be a radial neck fracture, and you can see how subtle these are. And probably before this person goes in a cast for a prolonged period of time, there should perhaps be another test to confirm the fracture or visualize it a little better. But here, going back to the very first view, it was here as well, and we can see it here extending towards the radial, the head of the radius, right here along the articular surface, this faint, lucent line. Okay, well that is about all the time that I have for on this presentation today. I want to thank you again for taking the time to listen to the talk. Again, we hope to hear from you. You have our contact information, and we'd love the chance to meet you and learn about your urgent care centers in the future. Thank you very much. Bye-bye.